The mechanisms implicated in chronic pain could be many different things. One of the things that could be is actually change in sensitivity of the neurons. It's felt that in patients that are in chronic pain, they have a lower threshold with peripheral and central sensitization. Okay? There's also maybe spontaneous impulses from regenerating peripheral nerves, which is what I was talking about before. When you have that amputation injury, you can actually have the peripheral nerve regenerating and the actual axon is now super sensitized. You may also get alterations in the dorsal root ganglia in response to peripheral nerve injury and neurotransmitters, which has caused reorganization in the nociceptive neurons. And you can also get loss of pain inhibition in the spinal cord or even in the thalamic area of the brain. Common types of chronic pain, the most common is low back pain, which accounts for about 14% in all adults of the United States. You may also have myofascial pain syndromes, which is injury to the muscle and fascia, which can cause spasm, tenderness, and stiffness. Myofascial pain is actually taken care of by a massage therapy. It's also been taken care of by doing trigger point injections on these patients. What a trigger point injection basically does is you're taking in a local anesthetic, usually 1/4% Marcaine, and you're directly injecting it to the muscle that it actually has a bundle in it. The spindle fibers are thought to be damaged in those people, so when you inject a local anesthetic, you're actually causing cellular destruction of the muscle. The 1/4% Marcaine is actually toxic to the muscle, and it causes it to dissolve. The muscle will then regenerate, and hopefully it will regenerate into a normal architecture, and then basically will heal properly. Okay? That's why we do, patients are given massages the same reason. The massage basically breaks up damaged muscle and allows it to regenerate properly. Okay? Some people require massage therapy chronically throughout their lives for this they have a higher affinity for developing muscle damage. So doing that chronic kind of therapy improves their symptoms considerably. You can also have chronic postoperative pain. It can be very severe, like thoracotomy pain. Post-thoracotomy chronic pain syndromes can be very, very severe and very difficult to treat. The other surgical procedure that requires a lot of damage is radical neck dissections, because you're going through the nerves, through the neck, and you're causing a lot of extensive nerve damage. Surgical amputation can also cause this chronic postoperative pain as well. If you go midline, that tends to have less pain chronically. The reason being is the nerves don't come in as a bundle. You're only cutting a very small portion of the sheath. So usually you don't get chronic pain syndromes when you're going midline in the surgical body. So when you do a sternotomy, you're going abdominal procedure, there's a lot less pain in association with chronic pain syndromes than the ones that go peripherally more to the lateral aspects of the body. So even gallbladder procedures, when you go and make a big gallbladder operation, you can have chronic pain syndromes associated with that as well. Cancer pain, of course, can be a pain attributed to advancement of disease. The actual direct compression by the tumor getting enlarged or due to avascular supply can cause severe inflammatory mediated reactions to take place. May also result from therapy, such as chemo and radiation, can cause extensive neurogenic damage, and also attributed to other coexisting diseases associated with the chronic cancer, such as vitamin deficiencies, nutritional deficiencies, and other problems. Neuropathic pain, on the other hand, is a result of direct trauma or disease of the nerves. Most often this becomes chronic, and the symptoms can be paroxysmal with paresthesias, which is tingling sensations of pins and needles. Patients can complain of burning or shooting or stabbing pain as well. The cause of neuropathic pain could be things like painful diabetic neuropathy. With diabetics, one of the major problems that you have with diabetes is that it causes microvascular damage. Microvascular damage means that any small little capillary or little arterial, because of the increased viscosity of the glucose, plus the glucose itself will actually cause detrimental free radical oxygen production, which causes microvascular injury. As a consequence, nerves that normally would be myelinated become unmyelinated, so they develop sensory afferent loss from that. Okay, so they don't get the normal pain response they do if they were stubbed the nose. As a consequence, these people have an increased risk already from the diabetes from forming infections, but now they're also increased risk for actually damaging the tissue, which then sets up the infection on them. So diabetic neuropathies can be very severe. You may actually develop what's called Charcot's joint, which means that the actual cartilage becomes damaged due to microvascular injury, but then the actual bone doesn't send the primary afferent stimulus back that's painful, so the cartilage just sort of degenerates, and then it goes bone on bone, and eventually the bone actually fuses, and you get what's called a Charcot's joint. Okay? You can also get things like postherpetic neuralgias, which can be very severe. This is not from herpes like you think, in the sense of it's from chickenpox. Chickenpox is a herpetic disease process. So it's postherpetic neuralgia from chickenpox. You can get this kind of disease. You can also get deafferentation pain, which means you get the nerve that gets cut. You can also get what's called sympathetically mediated pain, such as RSD, reflex sympathetic dystrophy. There's a lot of sympathetically mediated pain syndromes, which is why we talk about knocking out the nerves using paravertebral blocks or stellate ganglion blocks for the arm. There's also complex regional pain syndromes, central pain, and phantom limb pain. All these are neuropathic pain syndromes. Pediatrics and pain. Please, if you were taught this in the past, they would tell us, at least when I was a resident, that kids don't have pain because they don't remember it, so why bother treating it? And that's really not very humane. Okay, we treat animals if they're in pain. Why wouldn't we take care of kids? But at one time, medicine looked at children as being they don't have any pain, they can't perceive it, so why worry about it? But there is some significant detrimental effects of not taking care of people, of neonates and pediatric infants with pain, in the sense that they have an increased incidence of intracranial hemorrhaging. Okay, they get hypertensive and they bleed into their head. So that has significant detrimental effects, to say the least. So treating pain is actually an appropriate thing to do. Okay? The expressions of pain in kids are usually facial expressions. They go from crying to not crying, and you see a kid opening their mouth, screaming, and you hear nothing coming out of them. That's usually very severe levels of pain. Okay? That's not something you should take lightly. Usually that's associated with severe tachycardia and hypertension, which can cause some of the detrimental effects that you see. Body language also, of course, a kid tries to hide from you or stay away from you. All those are instances of pain. But kids are also perceptive in the sense that you'll see a kid who gets a small little injury and you'll look around. Okay? If he sees no mom, no dad, nobody around, he'll just continue to go back to playing. But if he sees mom, he'll immediately open his mouth and scream bloody murder like he's been killed, and he's actually just totally fine. So again, it's perceptual, and they learn that very quickly, and that somebody will actually say that, oh, you're fine. You'll have different cultures who will treat this kid differently. One culture will take the kid and say, hey, come over here, they take a look at it, you're fine. Tap him on the butt and tell him to go back to what you're doing. Okay? That kid will grow up just fine, versus a parent who comes in and says, oh, just poor you all the time. And now the kid has an incentive to have anytime they're in pain, to come back for that incentive. So you can actually cause more problems by inducing that. Not to say that you shouldn't be caring about your children, you should be, but to do it to a certain degree that you want to be a little bit stoic is maybe beneficial. Okay? Now again, that's my cultural bias. I came from a different kind of cultural bias where you had to be tough. So this is what you don't want to see in a child. You see this kind of activity. This indicates to you that first that kid's having severe levels of pain. You should treat it with a narcotic to control it. Some people don't believe that narcotics should be used in the operating room as well. They'll tell you that, oh, the person is going to stop breathing at the end of the case when you give the narcotic. My answer to that is you got to give it appropriately. That means you got to reduce your dosage and not give them so much that their breathing rate is below 20. So in children, you want to keep their breathing rate above 20 breaths per minute. Once you get below 20 breaths per minute, you're in the overdose range. Okay, you're getting too close to the overdose range. Kids don't breathe at normal, like adults, like 16, 14 breaths per minute. They're breathing at 20 breaths or higher. So as long as you stay to above 20, you're safe. If you're down to 14 breaths per minute, you're on the low end. And that kid, once you pull the endotracheal tube out, they may stop breathing. Okay, because you took away the discomfort they may be having. So be careful with that. Okay, don't overdo it. My trick to it is always give a little bit of narcotic. You can always give more. Okay, and just let them spontaneously breathe, and based on that, you can give enough narcotic to keep them respirations around 20. When you pull that breathing tube out, they're breathing right around where they should be, 16 to 18 to 22, and they'll be fine. Okay? Aging and pain. Okay, what happens when patients get older? Well, as you get older, your pain fibers can actually decrease in numbers, and the actual numbers of receptors are actually diminished. So, and there's also sometimes associated with them decreased pain tolerance as well. So it's sort of a weird situation. You have some people that have less pain receptors, and you give them a little bit of narcotic, and it goes really a long way. And other people where you don't have enough response when you give them a narcotic because their pain tolerance is actually diminished. Sometimes you don't have the central nervous system as well that's there to inhibit the actions. I can tell you from my experience, though, that most elderly patients, once you give them a narcotic, it goes a long way. And so just give it gingerly. It doesn't take much. Sometimes as low as 25 mics of fentanyl even for a hip procedure. Somebody asked me that's impossible. You can't do this patient under nitrous O2 and a little bit of Diprovan. And we gave a total case of 25 mics of fentanyl for the beginning of the case. And the patient woke up, the patient had no pain, and went to recover and totally comfortable. And it was a real eye-opener for the individual who was normally giving everybody 100 mics of fentanyl. You give 100 mics of fentanyl to that person wouldn't have woke up the next, and they wouldn't be breathing for you. So some people can be very, very sensitive as well. So it depends on their history behind them too. A lot of people here in Naples drink a lot. That's their primary medication that they use, which is alcohol. It's totally illegal, of course, but it cranks up your P450 systems, it cranks up your neuroreceptors. So sometimes you'll see this decrease, you see a tolerance to the medications. But even said, you give it to a woman who doesn't have any pain, who doesn't take any kind of narcotics or doesn't take any kind of alcohol at home at all and has lived a very clean life, 25 mics goes a long way. So you just be careful on who you're giving it to. Okay? Temperature regulation is something that's also very important for us in the sense that hypothermia is our biggest enemy in the operating room. We don't want to have people get hypothermic. They have a much higher incidence of having post-op myocardial infarctions. The actual metabolic rate increases around 300% increase when you're hypothermic to try to get you to normothermic by shivering. So that's a very detrimental thing for most people. Unless they can actually tolerate that increase in cardiac output, they're not going to do well post-op. And so you want to make sure that you maintain that person warm. One of the things that happens with anesthesia is that you suppress the central hypothalamic area that controls temperature. As a consequence, you usually use 1 degree for the first hour and about 0.5 degrees per hour after that, unless you do active measures to stop the heat loss. Okay, so we use bear huggers, warming blankets that we're using basically, and we're keeping the head covered as much as possible. 80% of your heat loss is through your head, so you don't want to do that. Okay? Temperature regulation, of course, is based on activity, environment, circadian rhythm. Gender is also important. Men tend to produce more heat than women most of the time. As a consequence, they tend to lose as much heat in the operating room as much as females do. Peripheral thermoreceptors are critically important. You also have central thermoreceptors. One of the central thermoreceptors is located in your spinal cord area, and that's why when you inject an epidural or spinal in somebody and the solution is cold, the person will start shivering. Okay, and a lot of times it's attributed to just that it's the anesthetic. It actually has to do with the coldness of the anesthetic you just delivered into the patient. One of the things that you'll hear when a person has an epidural catheter is when you inject a cold solution of the local anesthetic, is a person will complain that they feel like they just put a cold drop down their back. And the reason that they feel that cold drop is that cold fluid as it goes around the tubing, the skin senses it, but also when it gets into the epidural space, the epidural senses that it's being cold, and centrally then you activate the thermal regulators, which causes you to start shivering. Now there's one trick that's really helpful, and you won't read it in books, it's another little clinical pearl you're going to get from me. If you want the shivering to stop, there's one system that is very active that also is very important in shutting down thermal regulation, okay, in the sense of shivering, and that's your ears. Okay? If you look back in the pictures of the 1900s, especially of Holland, when they got all of a sudden a new ice age, all the women carried with them what? Earmuffs. Very good, earmuffs. The women learned very quick to stop them from, you never saw the men do it, but the women had the earmuffs, okay? Because women tend to be colder than men, so they're much more sensitive to cold. But they found that if they could put earmuffs on them, they would stop shivering. Okay, the same thing applies to this kind of problem. If you have somebody who's getting cold and shivering on you like that, even though their temperature is normal, just take a blanket that's hot, okay, we can get them either, and just put it against their ears, and it stops the shivering almost immediately. It's a nice, nifty little trick, okay? Maybe one of you guys will write about it one day. Anyways, I don't have time for it right now, but it's just something that I found that works, okay? There's the hypothalamic control mechanism is, of course, the central modulating system that actually controls your temperature. That is actually bathed in constant blood, so it actually knows exactly what the temperature is, but it's still not the primary mechanism. Sometimes the peripheral systems can overtake it and tell it to shiver, even though it may be warm centrally. The hypothalamic center, of course, controls things like thyroid stimulating hormone. The reason thyroid stimulating hormone is so important is it goes to the thyroid and it releases T4 and T3. And T4 and T3 then go to end organs and they cause increased basal metabolic rate to increase. Anytime you increase the basal metabolic rate of any kind of organ systems, including the liver and all the other systems, you're basically causing heat to be a byproduct of cellular respiration. Okay, so that increases your temperature. So you can actually get in thyroid storm, which is a very high level of thyroid release, a very high fever from it. Okay, that will mimic or be very similar to malignant hyperthermia. Heat production and conservation, there's chemical reactions and metabolism, of course. Anytime you take oxidative phosphorylation, one of the byproducts of that is heat production. If you normally were to take glucose and break it down completely using, let's say, fire to burn it up, you would produce around 2,820 kilojoules of energy. Okay? When you actually do it with aerobic respiration, which is oxidative phosphorylation, you actually produce around 1,280 kilojoules of heat, and the rest of it is produced as ATP, which is stored energy which the cells use. So about 45% efficiency we're looking at. Sorry, let's say the other way around. Am I saying that? 1,280 is produced in ATP, and the other of it is produced in heat. So only about 45% of the actual carbon, which is sugar, is actually produced into usable energy. The other 55% is lost as heat. So that's quite a significant amount. Okay? If the cellular metabolism isn't enough to produce your heat, then skeletal muscle contraction adds to it. One of the things that can really help you in situations where the patient's developing hypothermia and you want them to re-warm more quickly is you let them breathe spontaneously. Okay? If you let them breathe spontaneously, one of the diaphragm, which is a pretty major muscle, will begin to work as well as your abdominals, and that begins to produce more heat as well and helps you maintain temperature. Okay? There's also chemical thermogenesis. Vasoconstriction may also lead to difficulty in the sense that a central core maintains the temperature, but peripherally you can be very cold. This happens a lot in the operating room in the sense of post-bypass. We can sometimes see inappropriately vasoconstriction taking place in the periphery, and the consequence, the patient gets very cold after they've been re-warmed adequately. But when the core blood then transfers out to the peripherally, it gets cold again, and when the person comes off bypass, they get cooled down again on you, which is what you don't want to have. So vasoconstriction is something you don't want to do when you're coming off bypass. If you can avoid it, you actually want to vasodilate them so you can get an even heat distribution throughout the body. Voluntary mechanisms, of course, movement, okay, jumping around will also produce a tremendous amount of heat. Heat loss, the most common form of heat loss is via radiation. Okay, so radiation is the actual allowance of transfer of heat from an object traveling through space until absorbed by another object. Okay. Conduction is a transfer of heat from solid to another solid by touching each other. Convection is a transfer of heat by circulation or movement through liquid or gas. And evaporation is due to, of course, removal of gas from its liquid state into a evaporated state. Okay, so vasodilation exposes core temperature to the environment and increases the degree of radiation. So when you're putting somebody to sleep and you venodilate them, you're increasing their radiation rate. One of the things that you want to do is you want to cover the person as much as possible to try to keep the radiation down as much as possible. When you see the patients are completely declothed, okay, and then they're prepped with betadine or chlorhexidine solution, which is cold, you're increasing the amount of radiation exposure to the skin, plus you're also increasing the conduction that's taking place against the OR table. There's also convection that's also taking place as well. But by far the most important one where we get heat loss is due to radiation in the operating room. Okay. Most heat loss occurs from the head, okay, which about 80% of your heat loss is occurring from your head. People that are bald-headed have loss of more heat than people with full head of hair. Okay, so when you see your ancestors with a Cro-Magnon with a lot of hair, the reason he has so much hair is because it's decreasing his heat loss. Versus people who are in areas that were which are high heat, they don't have as much facial hair. Okay, it's more important for them to have less facial hair because they can sweat more efficiently and they tend not to retain heat as well. So people with more hair tend to retain heat better. Okay, one of the reasons that women tend to use long hair in the old days was they would wrap it around their necks and also keep their temperature down, keep their temperature from losing. So all these are things that you don't realize why you do things, but it's actually purposeful sometimes. There's voluntary measures that can be also used, of course, to keep you from losing heat, okay? And adaptation to warmer climates are, of course, something that occurs in different genetic phenotypes of humans, okay? Some humans are actually much better at maintaining in very cold environments by having a whiter skin or clear skin. You're able to radiate the heat and keep it inside you, so you're able to stay warmer better. If you're going to different locations of the world where there's a lot of heat, your skin will tend to be darker just simply from the genetic pressures of the environment. And that's why we have what we have in our life right now. So it's interesting how things have changed. Temperature regulation in the pediatrics produce sufficient body heat but are unable to conserve heat produced. Okay, even though kids small size, it has a high body surface to weight ratio and has a thin subcutaneous layer. So kids tend to die much more rapidly from hypothermia than adults. Okay, the way that adults protect the child is, of course, the mother would try to protect them by putting the child in between her and her chest. The reason they're putting the child against her chest is because that's core temperature, and the child is able to maintain that body temperature more efficiently. Aging is one of the problems that you get with aging is you get less water in the patient. They also have more slower blood circulation, and they have a more intense vasoconstrictive response at times, and their metabolic rate can't keep up with the increase in temperature loss. They get decreased sweating, and perception of heat and loss in cold can be more difficult for them to gauge. So people that are older in age can die from exposure much more rapidly than people of younger age. Fever is a resetting of the hypothalamic thermostat. Fever is not a bad thing. It's just got some bad side effects. But it's for survival mechanisms, fever has an important point in the sense that it increases the actual temperature that it tends to be bactericidal. It tends to kill bacteria. Okay? And that's why we actually have fever. So fever in certain situations may actually be good for you. We tend to overtreat fevers because people get so discomfort with it, and they do get increase in basal metabolic rate. So anybody you see with fever, you immediately notice that their respiration rate's elevated considerably, and if you were to check their pulse, their pulse rate would be comparatively increased with the respiratory rate. So if you see somebody with 103 fever, you'll see them breathing instead of 14 times a minute, they're breathing 24 times a minute, and their cardiac output is doubled. Okay, so you're really increasing the actual cardiac output significantly, which can put the person at risk, of course, if they have a problem with their coronary arteries. You can have things that actually activate fever, such as exogenous pyrogens. Exogenous pyrogens would be like bacterial cell walls, viral cell walls, things that are infectious in nature. Okay, you can have endogenous pyrogens, which are inflammatory mediated reactions that are produced by the body, which is why it's called endogenous. And there is also, it's very unrelated usually, but there's also endogenous cryogens, which actually make you colder. Okay, those are more of a rare compared to the pyrogens. Fever basically causes an activation of a multi-system effect, okay, and you get a febrile response with what's called an acute phase response, okay. The autonomics tend to be activated, and as a consequence, you get an increase in heart rate, blood pressure, increase in respiratory rate. The benefits of the fever is it kills many organisms. It decreases the levels of serum, of iron, zinc, and copper. All those are important components for bacterial survival. So by dropping these levels down out of the serum, you're basically making the serum less likely for survival for those bacteria to use as nutritional sources. It deprives the bacteria of food. It promotes lysosomal breakdown and autodestruction of cells. It also increases lymphocytic transformation, which means that it makes the white cells more like macrophages, which means that they are able to kill the bacteria more efficiently. Hypothermia is not mediated by pyrogens sometimes, but there's no resetting of the hypothalamic point. You'll see that sometimes you'll see fevers as high as 105.8, and this causes nerve damage, which can produce convulsions. Once you get up to 109.4, death results usually. The highest I've ever seen was 112 degrees Fahrenheit. It was pretty lethal. Okay, so you can see very high temperatures in people. Malignant hypothermia will drive you up very quickly to this point, and you've got to be very aggressive in treating it. The forms that you may see is you get heat cramps, heat exhaustion, heat stroke, and it's just basically a variance of the actual high the fever is getting. Heat cramps is a severe spasmodic cramping in the abdomen and extremities, followed by prolonged sweating and associated sodium loss. Now that means it's not real severe because you're still sweating. When you lose sweating, that's when you're in trouble. So that's heat cramps. Common individuals not accustomed to heat and those performing strenuous exercise in warm climates. This is typical of Florida when you have people that come up from here, from up north, like in Minnesota, and they don't like the heat here. I remember when I was living in the Canal Zone, we used to play football in 98-degree weather and 98% humidity. But we were accustomed to it. We played like that for 7 months out of the year. And so we got trained into it. When the kids came from the stateside, the parents would translocate to the base. They would have a really hard time. We'd have to watch them very carefully because they get into heat cramps pretty quick. So it takes about 3 months to get accustomed to that kind of heat before your body is able to acclimatize to it. You can get fever, rapid pulse, increased blood pressure, often accompanied by cramps. Heat exhaustion leads to a collapse due to prolonged high core and environmental temperature. You get prolonged vasodilation and profuse sweating. Leads to dehydration, depressed plasma volume, hypotension, decreased cardiac output, and tachycardia. You usually get dizzy, weak, nauseous, and syncope. You know, when you see kids vomiting, that's not a good sign. You should pull that kid off the field immediately. You know, you can see still coaches that are up north, they still get the kids to vomit here all the time. I usually go crazy when I hear that my kids are doing that. I said, you're to get off the field immediately because that's what they're getting. They're getting to heat exhaustion. It's not like that from just being over-exercised up north. You can see people get nauseous for a different reason. But in Florida, you get nauseous because you're heat exhausted. That's going to be very lethal. The next point, which is lethal, which is heat stroke. That's when you can die. Potentially lethal result of breakdown in an overstressed thermoregulatory system. And if you're in a football outfit and you're in pads and everything else, you're not sweating very efficiently. Okay, and then you got a helmet on, which is even retaining 80% more heat than you normally would. So one of the things that you're taught to do very quickly is as soon as you come off the field, you take your helmet off immediately, and it cools you down, and you pour water on your head. Okay, it's not good to do that too much because if you pour cold water on you, you can actually cause cerebral effects that are detrimental as well. So you want to just put like normal warm water on you just so you don't get, you increase evaporation rate and you make the person cool down quickly. But don't pour cold water on them because you can put them in shock. The brain cannot tolerate temperatures as high as 104.9. Some people have a higher fever production than others. My family usually has fevers in 104, 105 all the time. All my kids have 105 fevers all the time, and they don't have any severe detrimental effects. My wife's always in shock. She's like, I can't believe it. These kids are having such high fevers. So I've had that when I was a kid. My parents had that when they were kids. So people that have a higher fever threshold, that's normal for them. Okay, versus other kids who would get 104 fever, they'd go into seizures, and some people do as well. So you got to take it into the context that this book is basically stating that normally, depending on the individuals, high temperatures like this are not well tolerated, which it doesn't. The temperature maintained by blood flow through the veins in the head and face and the cardiovascular thermoregulatory centers may actually cease functioning with higher temperatures. Manifestations is you actually get cerebral edema to form. So these kids become confused. They're not able to focus properly. When you're telling them to look at you in their eyes, they can't seem to focus. And when you ask them to track, they start losing the ability to track your hand. That's a severe situation. You need to get that kid under cool temperatures, immediately begin to cool them, and get them to the emergency room, because that's not a joke. Do not just try to treat this in the field. Once you get that kind of effect, you need to bring them in to get them IVs put in them and rehydrate them. It's worth the visit instead of having somebody die from you. You get rapid peripheral cooling, which causes peripheral vasoconstriction and limits your core cooling. Children are much more susceptible. They produce much more metabolic heat when exercising. They have a greater surface area to mass ratio, and their sweating capacity is actually less than adults. Now, malignant hyperthermia is one of the issues that we have to deal with in the operating room. It's an inherited muscular disorder. It's most likely related to survival in the very cold environments up north. Scandinavians have a very high tendency for malignant hyperthermia. So if you have a history of having Scandinavian origin in your family, there may be a possibility that you may have a history of malignant hyperthermia in your family. The reason this is because most likely it's environmental stressors, we think. If you think about it from the standpoint, if you have a group of 100 people, and one of them has this abnormal, or two people have this abnormal gene, so they actually produce increased shivering, and they're in the middle of a snowstorm caught in it. And the only people that actually can tolerate the minus 30 degrees are the two people that are shivering vigorously, and the other people die from hypothermia. Then you take the gene that those two survivors, because they've actually produced enough temperature because they're shivering so vigorously, that now they can pass it on to the next family group. Okay, and that's how you get that very high gene population for picking out a certain kind of a gene that would normally kill most people. Okay, so as long as malignant hyperthermia is triggered in very cold environments, those people don't die. They do just fine. Okay, you trigger malignant hyperthermia in a normal environment, on the other hand, you'll burn them up. Okay, so one of the things that we do is we have to shut down the mechanism, and we had to learn what malignant hyperthermia is caused by. Okay. Malignant hyperthermia is thought to be caused by an inherited disorder of inability for the calcium channel inside the sarcoplasmic reticulum to reuptake the calcium. Okay? So in other words, you get prolonged contraction for prolonged periods of time. Okay? What dantrolene does is basically it's a medication that has three different kinds of things in it. Okay? It's got dantrium. Dantrium is the actual medication that helps inhibit calcium. Okay, so it acts like a muscle relaxer, because what it does is inhibits calcium release. So that person becomes weak. Okay? And as a consequence, if you give somebody dantrolene, you can't expect them to be breathing on their own without a ventilator assistance. So you keep those people intubated. Okay? You have to keep them intubated as long as you keep them giving them dantrolene. Okay? The other two medications that are also in dantrolene is, besides dantrium, is bicarb. Bicarb is in it to basically reverse the acidosis. The severe metabolic acidosis is due to the overproduction of acid from the metabolic waste product. And the other part is mannitol. Mannitol is also incorporated into dantrolene, so you begin to urinate out, okay, some of the creatinine byproducts. Okay? So it's a three-combo drug. When you get dantrolene, it looks orange. It comes in a bottle, and you have to mix it with what? Sterile water. Not saline, sterile water. Okay, the reason being is the sodium bicarb has what in it? Sodium. Okay, so it's hypernatremic, or it's actually like 154 milliequivalents of sodium in it. So if you were to mix it with normal saline, you would make it a hypernatremic solution, severely so. And so that's what you don't want to do. So you use free water and you combine it. Okay. It takes one person just to be responsible to mix the stuff. That's how hard it is to mix. It's not a joke. It takes you almost 3 minutes to fully dissolve the dantrolene once you start shaking it. So you have to just make one person responsible to use the medication. Okay, and you can go as little as 15 to 20 vials to as many as 50 vials of dantrolene. So it's a lot of stuff. Okay? Never work in a place unless you have dantrolene readily available. Somebody found out the hard way in Miami about 6 months ago. Okay, the young girl, 16 years old, questioned why they're doing breast implants on a 16-year-old, but they did a breast implants on a 16-year-old, and in the middle of the process, that she got severely malignant hyperthermia, and she died intraoperatively. Okay, they didn't have two things they didn't do wrong. One is they didn't measure temperature until it was too late, and then they didn't have any dantrolene at the facility where they were doing this at. You can't do that. If you decide to administer succinylcholine or you administer volatile anesthetics, you have to have dantrolene readily available. It can't be 20 minutes away. It's got to be readily available. Okay? So that's the first thing you ask about any place you ever work. Do you have dantrolene? If they don't have dantrolene, you go like, okay, see ya. Walk away. Because eventually, you can get away with stuff for a long time, but then when it gets you, it's a terminal event for your career. Okay? If somebody finds out that you gave dantrolene and you're giving succinylcholine or volatile anesthetics to somebody and you weren't having dantrolene around, your career's done. They'll take your medical license away from you and they'll prosecute you to the maximal point because it's negligent. Okay? And every expert will say that, so be very careful about that. What you see is a precipitation of the volatile anesthetics, and actually as well as the depolarizing muscle relaxants. The non-depolarizers don't seem to activate this, so like vecuronium, Pavulon, all those things don't really activate malignant hyperthermia. One of the things that I never do is in the books will tell you that you can use the anesthesia machine. My answer to that is you can't really tell at any time that your volatile anesthetics are not slightly on. There's some degree of leakage from the vaporizers into the circuit, and because of that, I never administer an anesthetic through the machine to a person with MH. I always make sure that I bring in a ventilator from the ICU, and I use the ICU ventilator to administer the medications to the patients, or ventilate the patients. But then I use Diprovan drip, okay, and make sure that a person's asleep by using a BIS monitor to make sure that you have no reasons for this increase. I've had 2 cases of malignant hyperthermia in my career, both on kids. Very scary, don't want to see them again. So you learn all the little tricks you can so you don't get into the situation. Here's the mechanism. We think that it's the reuptake of the calcium, okay, that's due to this MH gene, okay, that's causing the problem. So what dantrolene does is it inhibits the release of calcium right here. So the reuptake is the problem with MH. So this portion here is what dantrolene shuts down, and it inhibits the sarcoplasmic reticulum from releasing any more calcium. Okay. Hypothermia is a body temperature less than 35 degrees. It produces, unfortunately, vasoconstriction, alterations in microcirculation. It causes coagulation and ischemic tissue damages. It forms ice crystals, and tissue hypothermia slows the rate of chemical reactions. Increases blood viscosity and slows blood through the microcirculation, facilitates blood coagulation, and stimulates vasoconstriction. Now, the good thing about this is that the tissue hypothermia does cause the coagulation cascade to be inhibited. Specifically, the platelets don't work. Okay, so that's kind of a good thing. Accidental hypothermia is from prolonged exposure to a sudden immersion in cold water. This is somebody who's drowned in the lake or an ocean. You get therapeutic hypothermia, so what we do is use the slow metabolism to conserve ischemic tissue during surgery or limb reimplantation. It may lead to ventricular fibrillation and cardiac arrest, so you have to be very careful about hypothermia because it's not necessarily your friend at times. Trauma-induced temperature changes is that central nervous system can cause hyper or hypothermia. Most of the time we see hypothermia. Accidental injuries, hemorrhagic shock, which is you lose your heat with your blood. Okay, blood, when you transfuse it, is very cold. And one of the things I keep arguing with the emergency room is, please don't do me the favor of giving somebody blood downstairs if you don't heat it first. Okay, and don't microwave blood. It's not a smart move. I've seen that done. That was real stupid. That doesn't work well. Okay, so don't microwave blood. Okay, and you want to use your level 1 infuser if you're giving blood to people because you're trying to get the temperature warm up quickly. Okay, so hemorrhagic shock and giving cold blood is not a good idea. Major surgery and thermal burns can also be major points of evaporative loss and radiation exposure because now you've increased the body surface area when you open up the abdomen. Okay. The next point is where we'll stop here, give you a 10-minute break, and we should finish up in the next portion. Okay?